So today's talk, of course, is presented by Dr. Kathy Shear, Professor of Psychiatry and Social Work at Columbia University. The title of her talk is Treating Prolonged Grief Disorder, a Post-Loss Stress Disorder. Next week's Grand Rounds will be one of in a series of spotlights on innovations, highlighting the work of three early career faculty, Coriana Sechel, Bernadine Waller, and Stephanie Rollin. The three talks are very closely aligned in that they all deal with violence, aggression, and are fit with the theme of the domestic violence theme of the month. To let you know about our current Grand Rounds theme, we are presenting Dr. Shear as part of our clinical series Grand Rounds. And we are very pleased to have Dr. Shear join us as she is the Marion E. Kenworthy Professor of Psychiatry at the Columbia School of Social Work. During her career as a clinical researcher, she has conducted studies in anxiety disorders, depression, and grief. Her research studies and clinical supervision included a wide range of psychotherapy methods, including CBT, DBT, EFT, IPT, and MI. So a bit of an alphabet soup there. She attended graduated from honors from the University of Chicago and attended Tufts University Medical College. After completing her residencies in internal medicine and psychiatry and a research fellowship in psychosomatic medicine, she joined the faculty at Cornell, where she established the department's first clinical research program in anxiety disorders. She served as professor of psychiatry at the University of Pittsburgh before moving to Columbia. She began studying complicated grief in the mid-1990s. A 2005 JAMA publication of her work introduced her novel integrated psychotherapy, CGT, as the first treatment for complicated grief found to be efficacious in a randomized controlled trial. Dr. Shear has regularly worked with community partners, including mental health clinics, city-state agencies, and Black Baptist churches in conducting these studies and in disseminating the results. In recognition of her work, the provost at Columbia University authorized the establishment of a Center for Prolonged Grief in 2013. They were instrumental in the process of inclusion of PGD in DSM-5-TR. Dr. Shear is the recipient of clinical and research awards from Association of Death and Education Counseling, a Lifetime Achievement Award from the Neurobiology of Grief International Network, and the 2024 Award for Research in Psychiatry by the American Psychiatric Association. And oh my goodness, Dr. Shear, we are so pleased that you are in our community and that you are joining us today. So thank you very much.
Thanks so much. And let me share my screen. Here we go. It's a pleasure to be here and hopefully to provide an update. It isn't the first time I've presented at this, as I think many of our faculty is true of many of our faculty, but I'm going to talk today. It's kind of an update on the topic of complicated grief, prolonged grief disorder, and really as a post-loss stress disorder. Part of what I'm going to be talking about is prolonged grief disorder as a post-loss stress disorder. And also I'm going to touch on some of the issues around reward system that are on a lot of people's mind in this field at the moment. So those are my disclosures. And I wanted to start out with a reminder that we only have had this diagnosis for a little over 2 years. On March 18th of 2022, when there was a public announcement of the official criteria in the form of the DSM-5-TR, the publication of the text revision, and the New York Times was poised to answer that with an article that had, at the very least, a misleading title. And that produced or was associated with, I should say, a a lot of controversy around this diagnosis, which has continued, I would say, to today, although I think gradually people are understanding it better, and as they understand it better, accepting it better. So the confusion has been both with, should this really be a diagnosis? And also, why isn't this depression? This is just depression, is what it is. As Benjamin Sadek, who I think we all know, or at least know of, we've read his book, wrote to the New York Times in a letter to the New York Times that they published. Okay, let me just. So what I'm going to talk about is understanding how I understand PGD, how our team has understood it, and how that understanding contributes to, or really guided the development of the treatment that I'm going to just briefly review with you, and say a little bit about why it's not an answer to the question of how long it should take to grieve, as the New York Times said, nor is it a form of depression, as Dr. Sadek seemed to think. And so I'm going to talk a little about treatment and then tell you a little bit about our work at the Center for Prolonged Grief, which is where you can learn more if you want. So the first thing that I thought about when I was approached in about 1995 to see by the depression researchers, Chip Reynolds and Ellen Frank at the University of Pittsburgh, who are really very experienced depression researchers. They were at the time, and they still are. When I was approached by them to see if I could help, because they were finding that treatments for depression, medication, and IPT, which they were doing studies of at the time, were not affecting the grief symptoms that Holly Prigerson, a postdoc fellow at the time, was measuring. So I was doing anxiety disorder research, and I was also very interested in attachment. I've been interested in attachment since medical school. So it intrigued me to try to work on this problem, but it seemed like the first thing we had to do is to figure out what exactly we were dealing with. And obviously, to understand any form of grief, and PGD in particular, we need to understand loss. And we need to understand what it is we have lost in order to understand how we're responding to loss, because grief, we're going to be defining grief as the response to loss writ large. So it's not just an emotion, it's really, it's a full body and mind, and actually also a social response to a person's death is what we're talking about here. Also, our work has all focused on grief after the loss of a loved one. And I thought that attachment theory was the best place to try to understand loss. And these are things I think everyone in this audience is very familiar with, but because attachment is the underpinning of our close relationships. At least it's a way of understanding them that makes sense to me, and that I think clinically makes sense. And attachment, so we're talking about attachment. Attachment is one of a number of biobehavioral motivational systems in this way of thinking. And I think two other ones that are important in grief, very important in grief, are the caregiving system and the exploratory system. So attachment and caregiving are really, really important in our lives. Obviously, we all know that. They give us, our attachment relationships provide us with a safe haven and a secure base, is how we summarize that. And as caregivers, we want to provide that. And one of the interesting things that I learned early on is that while being effectively cared for is, of course, very, very important to infants and children, and that's kind of where attachment theory started, it turns out that being an effective caregiver, that if you compete being a caregiver, an effective caregiver as an adult, with being effectively cared for, being an effective caregiver is more important to our sense of well-being as adults than is being effectively cared cared for, though I'm not suggesting that it's not important for us to have our own secure base and safe haven, because it definitely is. But then the other thing that I started to learn about when I started this work, because this was work that primarily comes out of the laboratories, well, a number of laboratories, but two major contributors here were Marion Mikulincer and Phil Shaver, and they were doing a lot of experimental studies, laboratory studies, psychological studies of the effects of actually the attachment security is what most of these studies relate to. But that's, I think, a way of saying that attachment working models have an effect on a whole range of psychological and physiological functions that, we didn't really start out necessarily knowing. And there's at least one reference to each one of these, and I actually haven't updated this slide in about 10 years. So there may be, there are some more of these around, but it was pretty striking how pervasive the influence of our attachment relationships are behind the scenes. And so that's going to contribute also to the reaction to separation and loss. And basically, the reaction to separation and loss on this slide doesn't include the physiology, but there is a physiologic response. At least there appears to be. There's some studies that document this. There are studies that document a physiologic response as well. But the psychological response includes the proximity seeking, separation anxiety, separation guilt, anger, and feelings of widespread feelings of dysregulation, and as well as a tendency to loss of interest and loss of confidence in oneself, and loss of interest in the way that is not so much a pervasive loss of interest as much as it's a loss of being connected to what we're interested in. And if you look at how typical grief symptoms, they map very well onto these separation loss responses that we expect based on, from a perspective of attachment theory. So from this, and also from reading C.S. Lewis's book, A Grief Observed, we kind of came to the conclusion that grief actually is a form of love. And I think it's an important concept. That's one way to understand grief. But that's not the only way, because also we know that grief is a huge stressor, grief itself is a huge stressor, but loss of someone close is one of life's most intensely stressful experiences. And I think that's partly because the loss itself is hugely impactful, but also it brings along with it just a myriad of other experiences that are also very, very stressful. And the power and the complexity of grief itself is stressful, partly because it's so intense, and partly because it's so emotionally intense and so preoccupying. And so it's the loss is stressful, but then people also worry about their grief. They feel sort of discombobulated, disoriented by the intensity of the feelings that come and the sort of erratic nature of the way they can appear, and the way that the grief itself can be kind of confusing, because we don't want to have it, but we also do want to have it, because we recognize it in a way as a form of love, or certainly as connected to the person we love. And so we have all these mixed feelings and confusing thoughts. So coping with loss is going to be complex. It's going to require coping with these stresses from a lot of different sources. But the bereavement field, since 1999, when Maggie Stropy and Heng Shute published one of the most impactful papers, it's really it's an intensive review and a proposition that we should not be focusing are thinking about grief and loss primarily on the loss side, but rather we should take into consideration really from the very beginning the restoration side of what has to happen after someone close dies. And so the loss focus focuses on accepting that reality to some degree, or actually dealing with it, really dealing with the stress of accepting the reality, and finding ways to think about the loss, and then alternating really with avoidance of that very thing. And that's something Bowlby points out also, that we really need to oscillate between confronting the pain and setting it aside, because the pain, of course, is there, it's pervasive and it's permanent, and it's too much for us in the beginning. So we need to be able to alternate, to sort of what he called have bouts and respite, or bouts, and he called them bouts and moratoria. And then we also need a restoration focus. But in thinking about this, coping is really not exactly the same as adapting. And what we really need to do is to adapt to a whole new inner and outer world, basically. And of course, we use these terms interchangeably. Sometimes we use them together, like adaptive or maladaptive coping. But I'm going to say, I sort of started thinking that I actually got this from the climate change literature, which may seem like an unusual place to understand psychological functioning. But in any case, coping can be seen as more short-term and time-limited, more specifically focused on a stress that's here right now. And when the stress is removed, you don't have to still cope. And so it's motivated when there's a threat or a problem or a stress. And it tends to use resources. That's what the little image shows. Whereas adapting is more of a long-term process, and an ongoing process, really, that entails adjusting to change, in this case, to loss-related change. And it ends maybe when the adjustments are optimized, for the adjustments for this particular situation are optimized. But we probably, we're kind of adapting. It's sort of what it means to be alive, is to be adaptive to our environment. And adaptation tends to build new resources, because it makes us more aligned to the world that we live in. So so another way to think about this is, from a psychological viewpoint at least, that what we're trying to do is to change our implicit or our automatic thoughts, feelings, and behaviors, so that we're really changing our automatic expectations and predictions about things. So we're not constantly being sort of confronted with this huge change in our life. And to do that, we need to accept the reality, the finality of the loss, the changed relationship to the person who died, and the other changes in our life, and also the permanence of grief. In a way, we need to understand that grief if we define grief as the response to loss, it's not going to be completed, really. We're not going to stop having some kind of response to the loss of someone that we love very much. However, that the nature of grief, the nature of grief is to change anyway. It changes from day to day, week to week, even sometimes hour to hour or minute to minute during the acute period of grief, and it continues to change and evolve over time. So we expect it to evolve over time, but we expect it to be permanent. And then we also need to restore our capacity for well-being, or to thrive, which we have conceptualized using Edward Dietschy and Richard Ryan's theory of self-determination, which basically has found what they found over and over in different populations, different age groups, different situations, different cultural groups, that we need to have, in order to thrive in our lives, in order to have an ongoing sense of well-being, we need to have a sense of what they call autonomy, competence, and relatedness, which autonomy refers to doing things that are intrinsically motivated, things that align with our deeply held interests and our core values, and the things that we want to be doing for our own, for those reasons, as opposed to doing for someone else, or to accommodate or to please someone else, which also has its place in life, but thriving requires this intrinsic motivation. Competence means the sense that we can face and meet important challenges in our life, and relatedness to them means a feeling of belonging and mattering. All of these are affected by our close relationships, which is why we have to restore the capacity to thrive after someone close dies, because it tends to undermine all of these. And, as I said, adapting is a natural thing to do. We do it, living things do it, we do it naturally. This is such an important, our relationships are so important in our life. We obviously have mechanisms that sort of guide us in the adaptive direction if they don't get derailed. And the other important point for us is that as that process of adapting to the changed world occurs, our experience of the loss changes. And really, grief is the manifestation of our experience of loss at any given time. So as that experience changes, grief is going to be transformed. That's the idea. And this is sort of visual of what I just said. And if you like models, this one, I mean, if you like visual, I always like to try to draw when I'm talking about it so I can understand it myself. But it's a summary, I guess, too. And there are natural facilitators of this process of adaptation, things like self-care, entailing self-compassion, building and really experiencing a sense of agency, experiencing positive emotions. And there's some evidence, sort of indirect evidence, but I think kind of compelling evidence, that there is an implicit psychological immune system that kind of directs us to think in ways that promote adaptation to a change like this kind of change. Support from others is obviously important also. It's going to facilitate adaptation. And being able to balance that emotional pain and respite from the pain, that's a big one. But also balance other aspects of the experience of grief and loss, having to do with others. So some privacy is usually helpful, in addition to some ability to share thoughts and feelings and stories and such. And just physically being with other people and being alone has benefits often. So balancing these things, and then balancing also recalling the past and re-envisioning, or envisioning, it is re-envisioning usually the future. So we know that people with prolonged grief disorder, for example, very often are much more comfortable recalling the past than they are in envisioning the future. In fact, we have some unpublished data that shows that in one of our studies, this was documented, that the people who participated in our prolonged grief disorder study were better than a comparison group of, this was an older adult study, older adults in particular study. They were more likely to experience, or rather to recall the past in a positive way, than people who had also experienced bereavement but did not have prolonged grief, and much less good at the envisioning the future was almost always with a sense of dread or a sort of bleak vision of the future for the people with prolonged grief disorder. And so we know that adaptation can be derailed, and Bowlby actually talked about this as as defensive exclusion, which he believed was important, an important part of the grieving process. What he called mourning is the closest to adaptation, I would say, in his writing would be mourning. So the mourning process, he thought it was important to the mourning process to have defensive exclusion for the reasons I was saying, that you need these bouts in moratoria, but that that the criteria that most clearly distinguished healthy forms of those defensive processes from pathological ones were the length of time during which they persist and the extent to which they influence only a part of mental functioning compared to dominating it. And I would say, in our experience, it doesn't necessarily dominate completely. The defensiveness doesn't necessarily dominate mental functioning completely, but it does dominate the part of mental functioning that's around adapting or coping with the loss. And also some of the attachment system responses can be unusually intense and persistent. And we know that, for example, people with anxious attachment styles have special trouble with, or especially at risk for developing prolonged grief disorder. So that's probably what these are about. What this looks like clinically is difficulty regulating maladaptive thinking, like blaming, self-blame. Counterfactual thinking is very prominent in prolonged grief disorder, and seeing the future in overly negative ways. Those are examples. Ineffective emotion regulation related to either the painful or the pleasant emotions. In other words, people can have difficulty experiencing the pain. It's sort of overwhelming, and they have a lot of sort of self-criticism about it, and lack of self-competence around emotion regulation, or they can also have trouble with pleasant emotions. They can very often have survivor guilt, and they try not to have pleasant emotions, or they just feel like they, as I was saying earlier, they just want to be grieving because that's the way they can honor the person who died, and or that it would be kind of it would be a kind of betrayal to not do that. And then mostly the behavioral problems center around behavioral avoidance of reminders, seeking proximity. I'm going to talk about reward system in a minute, and seeking proximity is in a way, it's a manifestation of reward. It can be a manifestation of reward system functioning. So looking for that lost positivity. But I think it's also, in this situation, trying to avoid the feelings that are associated with the absence of the person. So I think it's also I think it's better understood in prolonged grief disorder as being a way of avoiding the feeling of absence. Okay, so here is basically what I've been talking about in infographic form. So what we're going to say is that loss is going to activate acute grief, which is a very intense, emotionally intense and pervasive and sort of preoccupying experience for most people. And it's associated with defensive coping, but the defensive coping is not persistent and overly influential. And when it becomes that, it sort of blocks this process of adaptation. So I guess one of the points about all this is that prolonged grief disorder is not a completely different way of grieving. It's not pathological grieving per se. It basically, in this model, occurs when the process of adapting to the loss is derailed by one of these ways. So what causes it is something like a perfect storm of personal vulnerability, relationship characteristics, circumstances of the death, and the social and environmental context of the death and bereavement period. And so, and why I'm saying this is that it's not really person related. So we don't see prolonged grief disorder after every loss of a close relationship in someone who has it after one loss, after someone's loss. It seems like it has part of the vulnerability comes from the specific relationship, characteristics of that specific relationship, and the way the person died, who was with them when they died, just the whole sort of circumstances of the death writ large, and then who's around and how they're around after the death. That all fits together. And what we're saying also is that it's a problem where grief continues to be intense and pervasive, which is what it naturally is in the very beginning for variable periods of time. For some people, it's very short. For other people, it's longer. For some people, it can be intense and pervasive. We've decided, I guess, it can be intense and pervasive, I guess, up to a year, although the ICD-11 says that should be 6 months, and it's really not clear, and it probably depends, again, on all of those perfect storm factors that I just talked about. But so these are common grief symptoms, and they don't go completely away necessarily in most people. So what we call continuing grief now. So the yearning and longing and preoccupation, which is central to this diagnosis and central to the condition, comes and goes in continuing grief. So it's not absent in continuing grief, and it can even be very intense at times. But its frequency tends to be variable over time. So it tends to be activated during what we call difficult times, anniversary times, special family times, quirky reminders of various sorts that can happen in a person's life for a long time after someone dies. But that's very different than the way that it's persistent and pervasive, really dominates a person's mental life in prolonged grief disorder. And the sort of other symptoms also come and go and play kind of a minimal role in coping with the loss. Whereas in prolonged grief disorder, they're persistent and pervasive, and there's still that need, there's still that ongoing stress of the grief and the loss that needs coping for long periods of time. And of course, disruption of ongoing life and the sense of well-being happens it's expected really right after someone dies. But with continuing grief, people mostly become re-engaged in their own lives, re-engaged with a sense of the capacity to thrive, with a sense of well-being, or there's clear progress in that direction, whereas that's not true for prolonged grief disorder. Functioning is still not on track, and progress, people will say, it's just like the person died yesterday. It feels like the person died yesterday. So these are some differences also from major depression. So instead of sadness and anhedonia as the core symptom, we have yearning and longing and preoccupation. And so we're going to talk then, I'm going to take a little detour into some questions about this reward system functioning that is clearly involved in prolonged grief disorder, sort of as my colleague and ex-Columbia postdoc fellow, now senior researcher in this area, Zoe Donaldson, has said the reward system needs remodeling, basically, in prolonged grief disorder. And that's not necessarily true in depression. And so we have waves of emotion mostly cued by reminders, either internal or external reminders, as opposed to the persistent dysphoric mood. Guilt is present in both, but it's almost always about caregiving failure or survival guilt. And rumination tends to be just broadly negative thoughts about the self, the world, or others. And whereas rumination in prolonged grief disorder is really almost completely centered on counterfactual thinking and or self-blame or anger related to the death. So that the tendency to counterfactual thinking after something we consider bad happens in our lives is universal, and we can do upward or downward counterfactual thinking. In other words, we can think about how things could have been better, or we can think about how things could have been worse. And mostly people trying to comfort bereaved people will try to do downward counterfactual thinking. In other words, they'll often say, you know, oh, it could have been much worse. Something could have been much worse. And that actually is not the way most bereaved people are thinking. Sometimes they're thinking that, and it is comforting. It is comforting to think that, emotionally comforting, but it doesn't work very well for most people when someone else says it. And there is suicidality. There's maybe some indication that it's at least as high as depression in prolonged grief disorder, and possibly higher. I don't think we have the end of that, but there's definitely suicidality. So we thought the reason why I was engaged to do this work is because my colleagues thought that maybe this condition was closer to PTSD than it was to depression, because they were, as I said, they were finding that depression treatments were really not helping the grief symptoms. And it made a lot of sense to me too. I think it's pretty close to post-traumatic stress disorder. In fact, I think that Naomi Simon's name, post-loss stress disorder or post-traumatic loss disorder, it would be a better name for prolonged grief disorder. That even though prolonged grief disorder makes some sense, it is kind of a prolonged grief disorder, but that's part of what has bothered a lot of people, because it feels like, to a lot of people, it feels like pathologizing grief, which I don't think we try to pathologize anything. I don't think we try to pathologize depression either, or PTSD for that matter. Anyway, these are some of the differences between PTSD, why we need a different diagnosis for prolonged grief disorder. We still do, even though the symptoms kind of match in terms of intrusiveness, avoidance, and at least DSM-4 kinds of symptoms. Okay, so I want to take a little bit of a detour into talking a bit about the reward system, because and it kind of relates to the treatment discussion, because the reward system is, I think, almost certainly very important to the clinical syndrome of PGD, but yearning and longing are often talked about as the manifestation of reward system activation and I guess unremodeled reward system functioning, the problem with reward system functioning. And almost certainly that is one of the manifestations. It's a core symptom of PGD, but it's probably not the only clinical manifestation. And it seems, I think we should be concerned about the importance of other symptoms, and also symptoms involved in the onset and maintenance of the disorder. So if we think about other reward system manifestations, there is a loss of sense of connection with core values and interests. I think that's something that's a reward system component also. There's a loss of sense of agency, loss of sense of social connection, very important, and the feelings of belonging and mattering in the world. All of that, I think, is also connected with reward system functioning. So we asked a while back, so Mary Frances O'Connor developed this scale called the Yearning in Situations of Loss scale. It's well validated, or it was validated. It was reasonably well validated. And we administered it in the two studies we did at Columbia. One we call the HEAL study. It was our 4-site study with 395 participants, and the other study was an older adult study with 151 participants. And what's interesting, I think, is that these are the proportions of people who endorsed each of these items, and I'm just going to go through this pretty quickly. And one thing you can see is that all of them, almost all of them, were endorsed by a high percentage of study participants. Not all of them were, and also they tend to be endorsed by about half of the group, with the exception of, I find myself wishing that things could be the way they were when I was with this person, and I miss this person as much or more than I've missed any other person. But then there are also highly endorsed items like, I wish I could do things that I used to do with them, or without them, I feel alone, or it's hard to imagine feeling as comfortable and happy as I was when I was with them. So there are other, and these are not, this is called yearning, but that doesn't necessarily mean that they correlate directly with yearning. In fact, one other piece of this is that we created with Sandy Comer and Abby Fire and Harry Shear, our team worked on taking Sandy's heroin craving questionnaire and turning it into a grief questionnaire. This is also unpublished data, but and we administered this as an addendum to the yearning questionnaire in those same populations. And what you see here is that there is an endorsement of, it would be difficult right now to stop longing for this person, but it's only around half of the population that's endorsing that. And these are endorsed less frequently, but they are endorsed. So I think it is interesting, and it is an indication that there's some relationship, likely some relationship between some ways of thinking about addiction and grief, which is one of the things that's out there today on the table that a lot of people are interested in. And the correlation between the yearning questionnaire and the craving questionnaire was quite high, 0.81. And the correlation with of the overall yearning, the 21-item yearning questionnaire with the single-item yearning questionnaire on the inventory of complicated grief was also reasonably high, but not, a high correlation is important. It doesn't mean that they're the same, right? So I would just suggest that there's more to reward system functioning in prolonged grief disorder than yearning. And this is one of the things that we also noted. This is a paper written by Angela Gesquire, a doctoral student at the time we were doing these studies, and we used the interpersonal support evaluation list as a measure of social support. And then what we found was really strikingly low values on this score, that strikingly low endorsement of social support across the board in all the different subscales. That it has like 4 or 5 subscales, the ISIL does. And as you can see, it's about half of what we were available for norms in the general population. And what was really kind of impressive was that the mean total score was lower than samples of previously published ISIL results from homeless and low-income adults. So it was, and really whatever other populations, this was way lower than anyone else. So this all informed, this kind of thinking informed our treatment, which from the beginning we targeted adaptation to loss. And we started actually asking Edna Foa to come and consult in our pilot study. We almost used exactly prolonged exposure. I think we added to that some grief monitoring, which I'm going to show you a bit about. And we did talk to them about grief a little bit more. But as we evolved this treatment from PE, so it still has its roots in PE. We also, from the very beginning, used some IPT strategies around rebuilding those relationships. But we then began to think of it as adapting, and adapting is a learning experience that needs to occur both cognitively and also experientially. So the treatment that we ultimately developed focused on what we now call 6 healing milestones, which address both restoration-focused and loss-focused adaptation. And each of them, we do psychoeducation around this and also one of these procedures. So understanding and accepting grief and managing grief-related emotions is kind of at the center, because that's something that that's where we start, because that's where people come to us saying, I'm grieving too much. That's why they come. So we start with grief, but then we move to a restoration focus with the idea that in order to first of all, it's more alliance building, and second of all, that giving people a little bit more of at least a hope that they can have a life after, if they are able to accept the reality of the loss, which many of them feel that they can't. We start with that. So we're just introducing these topics, and then they kind of track through the whole treatment. But then we do both that, doing an exercise to help them see a promising future and talking with them about that. And we bring someone into a session to start the process of helping to strengthen relationships. Then we move to the PE, like telling the story of the death and learning to live with reminders. We call it situational revisiting, and it's really an in vivo exposure kind of procedure. And then we end with helping them reconnect to the person who died. So even in spite of this, we always considered active listening to be the centerpiece of PGDT. And I think when we were reviewing all the T's, the CBT, DBT, IPT, there was also a strong, I guess, base of psychodynamic psychotherapy in my background. And that's where I learned to do active listening. And I thought it was profound. I mean, it was, I think, the single most interesting and exciting and effective thing that I ever learned, but that's just me. Anyway, we know that listening can be transformative. We know that for sure. We know it's important in building alliance, and we do know. Along the way, I connected with this person with a storytelling. The storytelling community. And this is some quotes from them, but I think, when we listen closely to what people say, they start to reconsider troubling ideas on their own. We've seen that over and over again in psychotherapy. But even transformative listening, it was clear in the beginning of this work that wasn't enough. So we added validation, support, and guidance to this, and these series of planned activities. So grief monitoring it's a little bit like mood monitoring or anxiety monitoring, but it's a little bit different because we ask people to take just a few minutes at the end of each day and look back over the day and identify a time when their grief was at its highest and rated on a 0 to 10 scale or 1 to 10 scale, and do the same thing with a period of time when grief was at its lowest. And so it's a very brief kind of monitoring, and it's also one that helps people start to see the importance and the actual occurrence, which they often are unaware of this oscillation process. Then we move to aspirational goals, which is a way of starting to see the future in a more positive way. We use a technique derived from motivational interviewing for this. We then have, as I mentioned, a session with a visitor, which is primarily psychoeducational and sort of helping them start the process of reconnecting. Then we do what we call imaginal revisiting, which is, as I said, a form of imaginal exposure. We do it very similarly to PE. And situational revisiting, very similar to in vivo exposure. And then we invite the person to have an imaginal conversation with the person who died. And so the order, I mentioned the order in which the milestones are introduced is sequenced. So we start with grief, move to the idea of restoring well-being, to instill a little bit of energy and enthusiasm and supportive companionship, just so that they have that to then do the harder part, which is, of course, doing the exposure-like exercises. And then we also sequence the content within each session. So we first, in sort of the opposite way, we focus first on loss and then restoration. And this is a 16-session semi-structured treatment. So it's semi-structured because it centers around that active listening. And so we're going to be fairly personalized about the way that we do this, even though we are trying, for the most part, we stick with the two structures that I just told you about. And this is the results of 3 NIMH-funded randomized trials. The first one mentioned was in 2000. We published in 2005. We started in 1999. It was the first study for this kind of condition, and we were able to demonstrate significant difference between what was called CGT at the time and IPT. We replicated that finding. Actually, it was a little bit stronger difference in our older adults. And then we did a study in which we compared, it was really a study designed to do two things, to first of all, to do a trial of antidepressant treatment for this condition, because there was sort of mixed results in a fair number of open publications, including one by our group, which seemed to show there might be some effect. And so we studied citalopram versus placebo, but we also wanted to have a pragmatic component to it. So we added, so we had citalopram versus placebo with a fairly robust warm pharmacotherapy management attached to it, grief-related pharmacotherapy. It was sort of like a grief support intervention that the pharmacotherapist did in addition to the medication. And then we also looked at the effect of citalopram versus placebo on results from the psychotherapy CGT. And so this was a 4-site study, as I mentioned, with Naiwa Dwan was the statistician for us. And we did it with Chip Reynolds, Naomi Simon, Chip Reynolds in Pittsburgh, Naomi Simon at Mass General, and Sid Zizuk, who's also been doing brief research forever, in San Diego. And what we found was basically no effect of citalopram versus placebo, and also no effect on the outcomes, which were very, very high, as you can see here, for CGT, both of which surprised us. We actually, that was not what we hypothesized. And this is a first study. It's been widely cited. It's still the only study of medication, the only randomized trial of medication for this condition that needs to be replicated. We all think that. One of the things we did find was that while it was clear that the psychotherapy was the treatment of choice for the prolonged grief disorder, co-occurring depressive symptoms are very, very common in this condition. Co-occurring major depression diagnoses also are common. And citalopram did optimize the treatment of the co-occurring depressive symptoms. And even though it didn't have that, an effect on the prolonged grief disorder symptoms, another one of so many indicators from the treatment literature that we don't treat prolonged grief disorder in the same way as we treat depression. But that finding was only true for the people who received the psychotherapy as well. So we didn't see a difference in depression outcome in just the citalopram versus placebo. And we did find in that study also that there was a pretty profound effect of PGT, or the CGT, which was the psychotherapy, on suicidal ideation. And we had a small sample, a small number had active suicidal ideation. It looked very similar to this. And that we didn't see that effect with antidepressant medication. We did some sub-analyses along the way. I'm just showing you a couple of them that come up often enough, but we found no difference in outcomes for violent versus illness-related death. And we found no difference in older adults compared to other more midlife adults. So I'm just going to end by telling you a little bit about our center. In fact, I'll just show you this very briefly, and then we can take some questions. So this is who we are. We provide information about grief and PGD and training materials, therapy tools, and handouts for patients and families. These are examples of some of the handouts we provide. We also usually have monthly webinars. We started with research webinars. They're on Fridays. I guess they're on Fridays at noon. Yeah. And we record them, and they're on our website. And now we have a clinical track as well, and we're about to start a social determinants of grief track in collaboration with Christy Denkla, the Harvard Chan School. So as of last spring, we had conducted over 3,000 on-site workshops. We've done workshops in 28 different countries and a number of states in the United States. We've distributed over 3,000 copies of our treatment manual, over 1,000 copies of a video self-study that we have available. And we just started about a year ago now, but 9 months at that time. And we have asynchronous tutorials that we've distributed, and we produced a full video role play of the treatment that was filmed with professional actors. That was done with a Provost grant at Columbia, and developed a mobile app called Grief Care for Families, which is now being modified as Grief Care for Harlem. I think recently during COVID, we connected with Professor Barney Dunn at Exeter in the UK, and he's very involved with the NHS TT system, which some of you may be familiar with. And so between April of 2022 and March of 2024, they trained therapists and did a pilot study, which the clinical response to this treatment in that setting exceeded the targets for depression and anxiety response. And we also did a pilot study. Henry Willis, who was a postdoc fellow with us and now is an assistant professor at the University of Maryland, did a study at the Hope Center in Harlem, collaborating with the Hope Center is a very interesting place. Maybe some of you are familiar with it. It's associated with the First Corinthian Baptist Church in Harlem. And it included solution-focused brief therapy. So they kind of combined using our Project Liberty PGDT manual, which is a shortened version of our manual, 10-session version. This is the intervention structure. And again, they had few outcome measures, but basically had positive responses and feedback from participants. So if you're interested in this, I encourage you to sign up for our newsletters, where you can see what we're doing, and all these different events get announced in the newsletter, and you can also go to the website. So I'm going to end at this point.